Thank you. Yeah, I think I have a special reason to thank for the invitation because I'm an economist and you have shown so many new opportunities for improving the situation for cancer patients. And then, of course, the health economist comes to say, well, there will not be money for doing all of them. We have to make choices. And, uh, and you have to provide evidence about which of all these options, which are the most cost effective. And I'm going to talk about that, and I'll see if I can move the slides as well. Oh, could you? Okay. It's upside down. Okay. Thank you. So health economics is about a relation between resources and outcome. And this is the same over the whole cancer continuum. All actions which we are taking in order to improve the situation for cancer patients are basically the same. They use resources and they produce outcome. And sometimes it's very easy to see if something is cost effective. If we can do 5 sessions of radiotherapy instead of 10, and we have the same outcome, that's rather easy to see that that's an improvement, both in terms of cost effectiveness and also for the patient. But you have to do the study. You have to show the evidence that actually 5 sessions is as good as 10 sessions. And the problem, of course, is also that someone's cost is someone else's income. And that's, of course, why we rather seldom see studies, so treatment optimization studies, where we actually could do less resource. We see it in cancer surgery. We see it also in radiotherapy. We see it very seldom when it comes to cancer medicines, where the most common economic problem is that, well, we can do something which is a little better, but it also costs more. And that's, of course, why you need to do an economic evaluation. How much extra does it cost, and what is the improvement in outcome? And health economists use an outcome measure, which we call the quality-adjusted life year, which is a very, very useful outcome measure. It's useful for all diseases. It is particularly useful in cancer, where cancer patients obviously would like to live longer and they would like to live better. And the quality gain is an area under the curve. You know that this is a complicated measure to actually get a precise measure. But as an economist, I usually say it's better to have an imprecise measure of the right concept than a precise measure of the wrong concept. And that's, of course, why this is important. If we are looking at quality as an outcome measure, it has the advantage that it can be used both for epidemiological research as a description of the situation. For example, we can describe the burden of cancer. We can look at the direct cost, the indirect cost, the life years lost, the quality loss, how much quality-adjusted life years we are lost. In WHO has a measure of disease burden called the DALYs, which is the disease-adjusted life expectancy, which in a way is in a similar way, but don't really have the same precise in the measurement as the quality. It could also be used as an outcome measure in economic evaluation. We can estimate the cost per quality. We can estimate the cost per life you gain. And we here always compare to the best possible alternative. And the idea, of course, is that if we are systematically using alternatives which has a lower cost per quality, we will produce more qualities, more outcome for patients with the limited resources which are available. And I will show one example here from breast cancer. It's a study which one of my PhD students did in now 20 years ago. It's breast cancer. At that time, it was just after the introduction of Herceptin. The direct cost of breast cancer was about 90 million euro in Sweden. The indirect cost, which is a loss of production from those who get breast cancer in the working ages, is actually more than twice as. But he also estimated how many qualis do we actually lose, and that we left 11,000 qualis. That's about 7 qualis lost for each death in breast cancer. If we try to put an economic value on the quality, we took 600,000, which is usually what we in Sweden think is reasonable to pay for a new drug. That cost would be 6.6 billion. So we could see in 2002, we have the major cost was the value of the qualis, the second cost was the indirect cost, and then the direct cost. After 2002, obviously we have significantly increased the direct cost, but of course indirect cost and quality loss has also been reduced. Interesting to see, my PhD student did this in 2002. I don't think anybody has cared to look into this after that, which is one of the problems. If we looked at cost effectiveness, we looked at that time at cost effectiveness in using Herceptin, both in early breast cancer and in metastatic breast cancer. And you can see that the gain in quality per patient is for early breast cancer 0.26 and for metastatic breast cancer 0.18. It's a rather small, but a small gain, but it's a gain, important gain for the patient. So the cost per quality was about 385,000 Swedish kronor, 40,000 euro, or about 60,000 euro in metastatic breast cancer, and this was seen also as acceptable at that time. If we are looking, I'm sorry, this is too small here, but you know, after Herceptin, we introduced the Perjeta, which was a combination therapy. Cost for Herceptin was about 50,000 euro. For Perjeta, it went up about 140,000 euro. The gain in quality in qualis was a little higher than for Herceptin. Cost effectiveness was not as good, but Perjeta was also accepted by the Swedish reimbursement agencies with a discount on the price. If we are looking further on, there is new drugs coming on, and I'm just going to the last one with Enhertu, which is also in metastatic breast cancer. Now we are up to a cost, with a cost in second-line metastatic breast cancer is about 300,000 euros. That's about what we invest in second line. If we are going earlier on, it obviously gets higher costs as well. So this is, of course, how the cost. We are continuously getting into improvements in quality-adjusted life years. But we also see, of course, that what is coming on is that a significant part of the gain from the new drugs is, of course, reductions in cost of using the old drugs. So if we are look at the estimates of cost effectiveness, which is now done by the reimbursement agencies to Sweden as the basic for prices, all of the estimates say that there's very high uncertainty. We can't really rely on this estimate. So what do? Well, we accept the price with a discount in order to cover. So this is the problem. It's always the same. It's high uncertainty in all the evaluations. So what's the problem? Well, the problem is, of course, a lack of relevant studies of outcome. It's one-arm studies, surrogate endpoint, few patients, lack of relevant comparison, short lengths of follow-up, etc. Even if breast cancer, as my example, was where we had better evidence. But if we are then looking real-world studies, So, of course, there is a large difference. In those cases, we do follow-up studies. There are large differences in survival between the follow-up studies and the correspondent trial. And those studies in general are of very low quality and cannot really be used for reimbursement decisions and clinical practice. So if you are looking at the cost of cancer, and I said the problem here is that we don't really have any data systematically on the cost of cancer. I could see that we had a lot of data of the epidemiology and so on, but I think the IARC should obviously have also publishing data about cost of cancer and quality loss of cancer. We can see here that between 2005 and onwards, we have a steady increase in the cost of cancer. But we also have an even stronger increase in the cost of cancer medicines. And in an oncology clinic today in Sweden, the cost of the cancer medicines is about the same as the cost of the medical staff. So this is growing at a very, very, very high rate. And it is, of course, the Swedish healthcare system and the Swedish taxpayers who is paying for all this. And of course, if we are looking at in the European context, we have huge variations in the healthcare expenditure, which reflect variations in income per capita. And since we don't have a European healthcare system, and we have these huge variations in income, the opportunities for countries, of course, of paying for these new medicines are very different. And this is very particular problem for cancer medicines, which is priced on an international market, while cancer surgery and other things is, of course, used by local resources. And that also, if we look at access to the newest medicines, looking at the lower tier countries with the income countries here, they are lacking very, very much behind in this, which is not surprising. And the newer the medicines is, the greater, of course, is the discrepancy. But I would like to stress that it's not important to have equal access to medicines which we don't know if they work or not. We should have equal access to the medicines which we know work. And that's, of course, also why information about cost effectiveness is so much important for the countries with lower income. This here is the spending on cancer research. And in the same way as this is spending by the blue here is the not-for-profits, the public sector and the private not-for-profit. They have a steady increase, but rather slow. But what is increasing very, very dramatically is, of course, the research spending in the pharmaceutical industry, which has gone up about 5 times during this year. The problem, of course, is that the pharmaceutical industry produce evidence for market authorization, but do not provide evidence for cost effectiveness. But from a taxpayer point of view, and this is, of course, also what general the healthcare system says, that now we are actually paying twice. We are paying first for the research, and then we are paying a second time when we are getting the new medicines to the market under the principle of value-based price. So what we need to do is, of course, to improve the situation. There is a lot of health economic studies where it's a very low quality. Reimbursement agencies lack the relevant data to assess cost effectiveness, and follow-up studies are rare and of low quality. And so health economics needs to be integrated in translational cancer research with a significant increase in resources for undertaking implementation and resource optimization. And I'm talking about significant. This is several times what we are spending on the moment, because if we are spending 50 billion on new cancer medicines, we at least need to spend 10% of that to find out which one are the cost effective. So my conclusion is that cancer research is biased towards spending on development of new medicines by the pharmaceutical industry. It's high prices paid by the healthcare system for new treatment with small or uncertain value for patients. And the recommendations for translation cancer research and health policy is that we have to fund studies at the European level, because all countries can benefit from knowing which treatment are the most cost effective. And of course, also in the different countries, we have to make decision on pricing and reimbursement based on the evidence. But otherwise, it's no meaning to do studies if we are not following the advice. And then, of course, options for prevention and treatment with no evidence of patients' outcome and cost effectiveness should only be used within framework for evidence development. So thank you very much for having me.